Okay, thanks everyone. I want to welcome you. My name is Susan Holtzman. I am the president and CEO of NAMI Miami-Dade County. We are the Miami-Dade County affiliate of the National Alliance on Mental Illness, and we provide education, support, and advocacy for people living with mental health conditions and their families. We want to welcome everyone here for tonight's presentation. This is a very interesting topic, and this is on top of being Mental Health Awareness Month across the country, this is Tardive Dyskinesia Awareness Month. So we always try to focus and have a presentation on this aspect of mental illness treatment during this month. And so now, with no further ado, I'm going to introduce our guest speaker tonight. If you've attended some of our presentations in the past, you probably already know Dr. Cordero. Dr. Nelson Cordero Torres is a caring and experienced board-certified psychiatrist at My Psychiatrist. Born in Mocha, Puerto Rico, he understands the unique challenges people from different backgrounds face and specializes in treating addiction, depression, anxiety, and other mental health conditions. He earned his medical degree in Puerto Rico, completed his psychiatry training at the University of Miami, and gained valuable research experience at Rutgers and Columbia University. Currently, he serves as Chief of Psychiatry at Broward Health Medical Center and Vice Chair of Psychiatry at Broward Health Imperial Point. Dr. Cordero is dedicated to providing kind, personalized care to help his patients live healthier, happier lives, and he's been an extremely helpful volunteer with us too here at NAMI. So thanks so much, Dr. Cordero. We're just thrilled to have you.
Hi, no, you're welcome, and I'm very happy to be here again talking to you guys. Like you mentioned, this May is the month of tardive dyskinesia. So when you guys approach me to talk about it, very something that is it's a topic that sometimes can be a little bit complicated, but it's something that is very extremely important to share and let other people in the community know about this condition, since awareness and early prevention are keys in how to treat or how to prevent this condition to happen in other patients or patients that are mentally ill. So I took the opportunity to talk a little bit, before I go in full details on tardive dyskinesia and what it is, to discuss a little bit about EPS or extrapyramidal symptoms, okay? Because all of them, as well as tardive dyskinesia, are related many times to psychotropic medications that we prescribe to the patient sometimes, okay? So how I want to approach this presentation in particular, I'm gonna go from early signs or the first few symptoms associated with EPS or extrapyramidal symptoms. I'm going to mention some of the conditions that are related to the medications. And ultimately, I'm going to talk about tardive dyskinesia, which is something that happens usually after years of being in treatment with antipsychotic medications. Okay? So first, we're going to talk about all the EPS, and we're going to close the presentation talking about TD. If at some point you have a question, please write it down, and I'm going to be more than happy to answer all of them at the end of the presentation. Okay. So extrapyramidal symptoms, this is going to be a comprehensive overview of drug-induced movement disorders. Okay. What are EPS or what are extrapyramidal symptoms? They are like drug-induced movement disorders caused by dopamine blockage in one of the pathways. Okay, I don't want to go into a lot of details, but in our brain, there are like 4 main pathways associated with dopamine. Okay, and when we block the dopamine in these pathways, is when we have the extrapyramidal symptoms. In someone with a normal amount of dopamine, that dopamine will help the patients to move and it doesn't have any changes. But once we start taking antipsychotic medication that we start blocking the dopamine in these pathways is when the problems can come, okay? Part of the EPS, we have acute dystonia, we have akathisia, we have Parkinsonism, and we have tardive dyskinesia. Those are like the main ones, okay? And like I mentioned before, they result from a dopamine cholinergic imbalance, mean you're gonna have less dopamine and more cholinergic activity because of the blockage of dopamine, by the medications, okay? It's very important to know that with the evolution and how we treat schizophrenia and bipolar disorder and the different use and newer antipsychotic medication, they have been able to put it in a certain way to clean the medication to target the dopamine blockers in places that we want. Okay, the prior and the initial antipsychotic medication, the old one like Haldol, Thorazine, Melaril, those medications they used to target to block the dopamine all over the brain. For that reason, we see when we treat the patients on those kind of medications for many years, is that when we have the extrapyramidal symptoms, something that is not as commonly seen right now with the use of the atypical antipsychotic medications. Okay, like I mentioned here at the last bullet point, most common with the typical antipsychotic, but they can still occur or can happen with the newer atypical antipsychotics. Okay. The risk factors for extrapyramidal symptoms is a patient that have never been on any kind of psychotropic medications. Let's say this patient that for some reason, like, have new onset psychosis, or the patient that try an illegal drug and become psychotic and they get to the emergency room, and in order to be able to handle the aggressive behavior of the psychotic state, they give him Haldol or Thorazine or any kind of antipsychotic medication and they never been on it before. That can lead to EPS. Okay. Other patients that are at risk factors are the elderly, especially females, also young males, and patients with intellectual disabilities. Okay, these four demographics, they tend to be a little bit more prone to develop extrapyramidal symptoms than the general population. In my experience, when we see it the most is with patients that are naive to psychotropic medications and they get it for the first time. It's kind of common for them to develop EPS, and it's something that we see often in the hospital. So if we go by time frame on when this happened, the first extrapyramidal symptoms or the first extrapyramidal syndrome that we will see is acute dystonia. Okay, as the name mentioned, it is something that happened within minutes of the patient getting the antipsychotic medication. Okay, if you guys have seen it, I'm pretty sure that you will never forget that patient because it's scary. Okay, and the tricky part is the patient knows what's going on. They're awake, they're alert, but basically they lost all control over their movement. Okay, as you guys see here in the picture, this is how it looks. They become like very stiff. It's like a sustained involuntary muscle contraction. You will see it mostly in the neck, in the face, in the jaw of the patient. Okay? And like I said before, it's something that it happened within minutes or hours. Okay? There's some documentation that can happen within days, but when you have an acute dystonia reaction, most of the patients is going to be within minutes or hours. Okay? Like I mentioned before, this kind of reactions is most commonly associated with high potency typical antipsychotics, being Haldol one of the main culprits for this condition. Okay? So here I'm going to explain a little bit of what happened. This is a little bit more technical. So basically in our four main tracks of dopamine tracks, there's one that is called the nigrostriatal pathway. Over there, when we block the dopamine, it increases the motor activity. So basically, without medication, we have a balance of acetylcholine and dopamine. and that create like a normal range of motion in your head, in your neck, in your extremities. So when we break that balance with medications that block the dopamine, mean there's no more dopamine in that area, you're going to have more cholinergic activity. That overreactivity is going to cause the dystonia and the Parkinsonism. Okay, so how do we treat this? It's pretty easy. We give anticholinergic medication such as cogentin or Benadryl. So let's say that you give Halo to a patient because they are psychotic, they've never been on any kind of antipsychotic medication in the past, and they develop this movement or this lack of movements. Very easy to treat. 50 milligrams of IM Benadryl or cogentin, 1 or 2 milligrams. The patient's symptoms will resolve on their own within minutes. And the patient is just gonna remember that it was a very scary situation, but beside that, there's no long-term consequences of the medication. Okay? So here, like I mentioned before, IM or PO, cogentin or Benadryl. Since it's a very scary situation, the PO, meaning the pill, will take a little bit longer to work. So go ahead and you can feel free to take the injection of the Benadryl, okay? It's very important to try to discontinue the medication and do not offer the medication again to the patient, okay? Because it's highly probable that they can develop another acute dystonia reaction if we give the same medication, okay? In the practice, we see many times that the patient come with allergies to Haldol or Zyprexa or Thorazine or antipsychotic medications. And when you ask the patient, so what kind of allergic reaction you had, they're gonna say, oh, I got like super stiff. And acute dystonia is not an allergic reaction to the medication, it's just a reaction or side effect from the medication. Okay? Okay. So that's the first EPS that can come is acute dystonia. Then we have a second one that is called akathisia. Okay? Akathisia, to put it in a simple way, they always tell us in residency, and when we talk to the residents, is like feeling like you have ants in your pants. So basically, it's that desire or that inner restlessness that you cannot control. Okay? Most of the patients, they don't know what akathisia is. So when they come to your office, they will tell you, or not even him, or not even the patient, maybe the significant other, the parent, whoever live with the patient, the roommate said, doctor, since X or Y started the medication, he's doing good, but he's walking all the house. He cannot sit still. He's always uh, anxious, walking up and down the hallway. If we sit down to eat, he can keep like moving his legs nonstop, and I don't know what's going on. I think that he's someone that is very anxious. So that when a family member, because usually the patient do not recognize it, when a family member tell you that that's going on with the patient, that should ring a bell and check what medications you are supposed to be on. Okay, let's say that all the atypical antipsychotics and the typical antipsychotics in theory can cause the akathisia, but the one that is mostly related to it is Abilify. And all the products or the medications that are derived from the Abilify. Okay? So like I mentioned before, there's an inner restless and objective motor activity, pacing, rocking. It can happen within hours of days of starting the medication. And maybe the patient is never had any kind of akathisia, and as soon as you increase the dose a little bit, then the patient develop the akathisia. So also it can happen when we increase the medication. It can cause agitation, anxiety, irritability, and one of the red flags with this particular EPS is that it can increase the suicide risk. So it's something that is very, very important that when you have a patient or a family member that is telling you that the patient have developed akathisia, to assess, do a nice suicide assessment risk, because this situation, patients can get so overwhelmed with this inner restless that they can try to hurt themselves. Okay. Like I mentioned before, the most common medication is associated with it is Abilify, but in theory, all the atypical antipsychotics or typical antipsychotics, they can cause it. Okay. In my personal experience, like the most tricky part to treat akathisia is that many times the patients are doing well in that combination of medications. They're doing well on the 10 milligrams or 50 milligrams of Abilify with an SSRI, or they're doing well with the Abilify alone and they're stable for the first time in a long time. So the patient tell me, doctor, this is something that is really bothering me, but I don't want to try anything else. I want to keep taking it because this is the first time that I'm stable. When that happens, it's very important for you to talk to the patient about the options that we have, okay? The first option, and many times like my first approach on how to deal with this, is to reduce the dosing. Let's say that the patient is stable on Abilify 50 milligrams PO daily. Then I said, okay, if you're stable, let's try to decrease it to 10 or 5 and see how things work, okay? There are other patients that said, doctor, the medication is helping me, I'm doing well, but I cannot deal with this. So let's try something new. If that's the case, you taper the patient off and start a different one, okay? The use of benzodiazepines such as Ativan or Clonopin, it can be helpful because, it will kind of relax the patient regarding this need of movement, okay? So that's another option. The tricky part with the akathisia is that if it happens and you start the benzodiazepine, most likely you're going to have to keep the patient in that benzodiazepine for a long term. And that's something that we always try to avoid as much as we can because, as you guys know, benzodiazepines, they can be addictive, and you don't want to fix something by creating addiction to a benzodiazepine. Okay. Other options that have been proved to be a little bit effective are propanolol, which is a medication for blood pressure. Okay. Basically, what that medication help with the restlessness, because as a beta blocker, it kind of masks those kind of things. We have mirtazapine, which is an antidepressant that help for sleep. And also sometimes patients have shown some improvement with a medication called cyproheptadine, which is basically an appetite stimulant. It's usually given to kids or patients suffering from cachexia or cancer that they do not eat well. Cyproheptadine is a medication that it can help with the akathisia, okay? Unlike the first one that we discussed, the dystonia, this one do not respond very well to cogentin or Benadryl. Okay, so like everything, a lot of communication with the patient is extremely important to see what will be the best course of action to treat akathisia, since it can be tricky. Okay, I would say that most of the patients that I have that they come with this problem, most of them we just reduce the dose and the discomforts go away. Some of them we have to switch medication, and some of them we have to add another one. Personally, I try to avoid keep adding medications because if even with one medication that we have to take a day and compliance sometimes is a big issue, you can imagine that, okay, so you're taking this and now we have to add another thing to deal with the side effects. So personally, I always try to avoid that and just try to reduce the dose or just switch to another antipsychotic. Okay. So here we have if we go by time frame, so we have the first one, acute dystonia, happened within hours or minutes. We have akathisia that can happen within most likely days to weeks. And then we have antipsychotic induced Parkinsonism. Okay. Just not to go in a lot of details on how the neurological part of Parkinson disease, but it's the same thing. Okay. Less dopamine in the brain, certain areas of the brain that are in charge of the movement. When we have less dopamine, patients develop Parkinson disease. So an antipsychotic induced Parkinsonism is basically antipsychotic medications that what they do is to block dopamine. They will block the dopamine in the same areas of the brain that Parkinson disease, and you will see the patients and they will look like someone with Parkinson, but they do not have Parkinson. They do have the same symptoms, but associated to the antipsychotic medication. Okay, they will have bradykinesia. Bradykinesia is, if you guys have ever seen a Parkinson patient, that when they walk, they give like very short steps and they're kind of a little bit of leaning forward. Leaning forward, that's the colloidal rigidity. They will have the resting tremors and they will have like no kind of effects in their affect, their face will look the same. You cannot tell if they're happy, if they're sad, because you will have like this mask-like face. Okay, they can have drooling, they can have postural instability and seborrhea. Okay, one of the first things that we will note with antipsychotic induced Parkinsonism is the tremors in the upper extremities. Okay, and remember that the tremor is resting. If they are not moving, and they're just not doing anything, they're gonna have the tremors. Let's say that they try to grab their cell phone. As soon as they move to start to grab the cell phone, the tremor goes away, and as soon as they stop, they will have with the tremor again. Okay, so it's very important to assess, and when you see a patient with this kind of features, to try to identify right away if the patient is indeed starting Parkinson disorder or if the patient is indeed going through an antipsychotic induced Parkinsonism. Okay, this one again, like the acute dystonia, is most commonly associated with the first generation typical antipsychotics, the old school, Haldol, Melaril, Thorazine, because they block dopamine everywhere in the brain, versus the new ones that they just block dopamines in areas of the brain that we want to do the blockage. Okay. Again, it's more common in the elderly with a 40% of incidence. Usually in this kind of patients, is like when we start seeing patients that develop like a behavioral component of dementia that many times we have to treat with antipsychotic medications, they are the ones that are most commonly presenting with the antipsychotic induced Parkinsonism. Okay, this part here is a little bit more, neurological in part. Uh, the D2 receptor is the one that is more in charge of the Parkinsonism, and when the typical antipsychotics block this receptor is when they mimic the symptoms. Okay, here I'm not going to go into much detail since it's a little bit more technical information. Okay, that I don't think that it comes to the case. Okay, but the most important thing here is to remember that a typical antipsychotic have a lower risk because they do not block the whole D2 receptors. All antipsychotics, they block dopamine everywhere in the brain. For that reason, all the extrapyramidal symptoms are mostly associated with them. New atypical antipsychotics, they just selectively block the areas of dopamine that we want. I think that is the most important thing to get from this slide. How do we treat it? The same thing. We can reduce the dose. We can discontinue the antipsychotic and try something different, meaning go from Haldol or Thorazine to something like Seroquel, Clozaril, or Zyprexa. And also in this case, cogentin in a 1 or 2 milligrams dose, it can help with the Parkinsonism treatment. Okay. I described in a brief summary like 3 of the first extrapyramidal symptom that we have, and then we go to what we came to talk to today, which is tardive dyskinesia. Okay, so remember, extrapyramidal symptoms: hours to days acute dystonia, days to weeks akathisia, and maybe weeks to month Parkinsonism. Now, when we talk about tardive dyskinesia, the word tardive means that is something that happened after many years of exposure to antipsychotic medication. Most commonly involved, the same here, the typical antipsychotic medications, meaning older generation antipsychotic medications, Haldol, Thorazine, Melaril, the old school antipsychotics, they're the ones that are going to cause tardive dyskinesia more than the new ones. The reasoning, the same. They block dopamine all over the brain versus blocking dopamine in certain areas that we want to block it. Okay, so let's go by tardive dyskinesia. The definition: tardive is delayed or late onset. They said 3 months is the rule of thumb. In my experience, it happened after more significant time. I personally, I have never seen a patient that developed TD within 3 months of starting as an antipsychotic medication. Okay. Tardive and then dyskinesia are normal movements. Okay. Movements varies from patient to patient, but they typically involve chorioatheoid movements of muscles of the head, limbs, or trunk. You will see that the patient do not have no control whatsoever. Okay. They're like, hybrid of quick jerks, snake-like breathing. They're not rhythmic like the Parkinsonian. In the Parkinsonian, you will see that the tremors, they are like in a particular rhythm. Not here. Here, they're more in a aleatory, jerky way, not with any rhythm whatsoever. The most common ones: upper extremities and the mouth. You will see that you're going to be talking to the patient and they keep protruding the tongue out, they keep moving the mouth, and they move the upper extremities, they move the head, and even though they can, or they're trying to stop this movement, they just can't. Okay? It's caused by exposure to dopamine receptor blocking agents. It can happen with any antipsychotic, but most likely is related to the typical antipsychotics. Okay? To put it in a simple way, let's say that, like I mentioned before, like there's this, collaborative agreement in our normal movements of our muscles between dopamine and acetylcholine. Okay? There's this normal balance between the two of them, and all of a sudden you give Haldol, which is going to block and kind of eliminate the dopamine. And when you take that medication for a long time, the receptors that are there in the brain, they're going to react to anything. Like the smallest amount of dopamine that they get is going to trigger a movement. And that's, in a simple way, to put how did this work. So you block dopamine for so long that even just one small particle of dopamine that get to that receptor is going to trigger like a big movement. Okay. Some of the medications for nausea and throwing up, like Reglan and Compasine, they have been shown that they can cause tardive dyskinesia. In patients that have suffered very chronic condition that take these medications on a regular basis, they can develop TD without ever being on an antipsychotic medication. So that's something that can happen. But most commonly, we see it with typical antipsychotic medications. That's the reason that most of the patients that you're going to be seeing TD are patients that are, I would say, 50 to 55 years old and older. Why? Most likely they were diagnosed with schizophrenia 30, 40 years ago, and they took the typical antipsychotic for maybe 10, 15 years. They developed the TD, and now we came with new medications. But once we have the TD, there's no way back. Okay. There's some treatment that I'm going to talk a little bit in another slide, but that's something that is fairly new. Okay. So, schizophrenia as an independent condition can also increase the risk of movement disorders. Okay, so that's something that it can happen even if you never take any kind of psychotropic medication. But adding an atypical antipsychotic or a typical antipsychotic can lead also to higher risk of movement disorders, including tardive dyskinesia. Okay. So this is what we see most commonly in a patient that is going through or is expressing this condition. Okay. The tongue is the most common site for the first occurrence of TD. Let's say that you have this patient, you start him on Haldol or Thorazine or maybe an atypical antipsychotic, and they come to see you within weeks, within months of taking the medication. And while you're talking to him, you see that they're like protruding their tongue. That's a red flag. So if you see that, you have to right away do an abnormal involuntary movement scale to address if there's other movements that the patient is having, because that's the first sign. Okay. And it's very important that we identify that first sign, because if we catch it early and we make the right medication adjustments, it can be very beneficial to the patient, and the things do not continue to progress to involve other muscles of the patient. Okay. Then, like I mentioned before, bucolingual masticatory syndrome. You will see the patient that is, you're talking to them and they look like they're like chewing gum or chewing something, but they do not have nothing in the mouth. Okay. The same thing about the tongue, the vermiform tongue, which is a worm-like writhing. Okay. The tongue darting, tongue protrusion. The bon sign is something that when the patient keep pushing his tongue against the cheek, like again, like they were chewing candy, that's something that also of the one of the movements of TD. Lip pursing, grunting, gasping, sighing. Those are things that are movements that are dyskinetic movement from the diaphragm. As you guys know, before, the diaphragm is our main muscle to make sure that we breathe properly. So that muscle, if it's not going with the right flow, you can have like these kind of symptoms like gasping for air, grunting, and sighing. So those things are a little bit more severe. They're not very familiar. They're not very common with TD, but it's something that can happen. Also, something that can happen that it can be a little bit more complicated is dysphagia. That is that you cannot swallow anything. Those patients sometimes have to end up with a feeding tube, because the muscles that are in charge of swallowing the food, they're just not working properly and they cannot properly swallow the food. The opposite, instead of being able, and they can swallow, but at the same time, as soon as they swallow, the muscles involved in the stomach, they push the food back, and they have episode of retching, vomiting, throwing up. Those are cases that are a little bit more severe. And something also that is very common is the excessive eye blinking. Okay, so in my experience, like a typical patient with TD will express all of them at the same time, except the grunting, gasping, or dysphagia. When the patient got to that level, things get a little bit more complicated, but it is not that common. But all of the other ones, in someone with TD, you're going to be talking to the patient for 25, 30 minutes, and you're going to be able to see all of them at the same time, or all of them in different times. So TD is often masked, okay? Why do they say that? Because sometimes, who develop these kind of symptoms? Patients that are schizophrenic. Many times they've been schizophrenic for years. And like I mentioned in one of the prior slides, schizophrenia per se can come with abnormal involuntary movement that sometimes they look like TD, or they look like the Parkinsonism, or they look like akathisia. So if the doctor is not very, careful, this can go unnoticed until it's something that is more permanent. For that reason, right now, in all our outpatient practices, they are encouraging all the practitioners to do an abnormal involuntary movement scale. So in that way, you can have a track record of these movements between visits. And things can change from 1 month to 6 months. So it's very important that we keep track of the aims. Okay. Why also they said that it's masked is because the movement, they can be related to an emotional state. If someone is not very compliant with the medication and keep getting to the hospital regularly, and he gets to the hospital always kind of agitated or moving or pacing up and down or making weird gestures, the doctor, if he doesn't know the story well, or he doesn't know what's going on, they might confuse, like, oh, the psychosis is worse, and what we're dealing with this is rather, no, the psychosis is the same. What is getting worse is the TD. Okay. TD may coexist with Parkinsonism, with acute dystonia, or with akathisia. So you can imagine someone that is already having TD, that at the same time is the Parkinsonism is getting worse, or they develop akathisia with a new medication, all the stress that can cause to him. And like I said in at the beginning of the presentation, it is very, very, very important that we address and assess extrapyramidal symptoms, because if they are not under very good control, they can lead to suicidal ideas or attempts. Okay. Also, like activating movement, like finger tapping, extending the arms out, palms down, walking, those kind of things, you can confuse them by, oh, this patient is just decompensated, he's just psychotic, and let's just increase the medications. So that is going to make everything worse. So it's very important to always have into consideration that some of the physical presentation of the patients can be associated with an extrapyramidal symptom and not purely the psychosis. Okay. So here is a little bit of how it happened, the incident and the lifetime risk. So thank God, like right now, TD is not something that we're seeing very often. Okay. With the evolution of psychotropic medications, with new medications coming, with the new atypical antipsychotic medication, it is extremely likely that someone that comes with the first time with a psychotic break at 18, 20, 21 years old is going to be started right away on Haldol or Thorazine or Melaril. Most likely, they're going to get treated with an atypical antipsychotic such as Zyprexa, Risperdal, Invega, Abilify, Geodon, whatever of the, whichever of the new antipsychotics, they're going to be treated with that. And we've been treating patients with the new antipsychotics for at least 20 years now. Okay, for that reason, because a typical antipsychotic have less dopaminergic blockage, is that TD is something that we don't see it as often as maybe someone that was practicing psychiatry in the 90s or early 2000. Okay. And still, we have around 100 patients a year, like meaning like 10 cases per 100 treated patients. And then we have around 3,000 patients for like 30%. Okay. The lifetime risk is between 20 to 50%, but like I just mentioned, with the use of atypical antipsychotics is something that we are seeing less and less, okay? Like all the EPS, first generation antipsychotic medication, they have a higher risk of TD. Second generation reduce the risk by 30 to 60%, okay? There's some research study that kind of is not that promising regarding on how the reduced risk is. But again, in my experience, it's something that we are not seeing in younger patients. And the patient that we usually see with TD are patients that are 50, 55 or older that were treated with typical antipsychotic medications in their teens or 20s. And that's the reason that they develop it. There's some research from 2010 that what I just said, they said, you're too optimistic. I don't think that that's something that we're going to be able to eliminate. But again, in my experience, it's not something that I'm seeing with the new atypical antipsychotics. Okay. Here is the pathophysiology of tardive dyskinesia. Like I said, it's a lot of science and it can be very complicated. But just to see it in a simple way, dopamine, acetylcholine, they live in balance. And because of that balance, we can move all our extremities in a normal way. When we block the dopamine for a significant amount of time with a typical antipsychotic, even the smallest dose of dopamine that reach those receptors is going to trigger like the abnormal involuntary movements. So you just imagine that you have like your 3 meals a day, your breakfast, lunch, and dinner, and you're living in balance. Everything is fine. No issues, you do your thing. But let's say that all of a sudden, for 2 years, they will give you only dinner. And you're super hungry, you miss your breakfast, you miss your lunch that you're used to it. And around 12 p.m., like something in your brain shows a hamburger or your favorite food, what are you gonna do? You're gonna jump and grab that burger before they take it away. It doesn't matter that you haven't had breakfast or lunch for years. You know how a burger for lunch is, and you're gonna jump and get it. This is the same how it works. So that dopamine receptor is not getting too much dopamine. A small dose of dopamine, see it, jump and get it. And when you get that small dopamine, it's going to create all these abnormal involuntary movements. So that's the easiest way to explain this slide per se. Okay. These are like other theories about oxidative stress and something that I don't think that are pertinent to this particular presentation. Okay. Something that is very important. Okay, we might have tardive dyskinesia, but we have to rule out all the things that can present or behave in a similar way. Okay, those kind of conditions that can present in a similar way, most of them are neurological, such as Huntington disease. As you guys know, Huntington disease also involves like a lot of abnormal involuntary movements. It's a genetic condition, so that doesn't mean that if you have schizophrenia and you're taking typical antipsychotics, you can have Huntington disease. So that's something that you have to rule out. There's a Wilson disease, which is a liver condition that basically kind of accumulate toxins in your brain that led to abnormal involuntary movement. Okay. Drug-induced dyskinesias, for example, there are some of the medication like lithium, SSRIs, TCAs that can cause dyskinesia. So that's something that also we have to rule out. There are other conditions, strokes, like immune-related chorea, which is like a genetic condition. And, there's all the spontaneous or facial dyskinesia. So there are other dyskinesias and other abnormal involuntary movement that we have to rule out or we have to take into consideration before diagnosing someone with tardive dyskinesia. Okay. The risk factors for it, age. So if we have advanced age, you're more vulnerable to rapid onset, and it's more likely to become irreversible once, if you are in an advanced age. Female, they have higher risk factors. African American, they have higher risk factors. longer use of dopamine receptor blocking medication, meaning if you take Haldol for 3 years, you have higher risk factor than if you took Haldol for 1 year. Also the dose. Someone that take Haldol 5 twice a day, less risk factor than someone that is taking Haldol 10 twice a day. Pre-existing mood disorders, someone, a schizophrenic patient with prominent negative symptoms rather than positive symptoms. When you use alcohol and drugs, if in top of the psychiatric problem you have cognitive impairment, early dementia, mild cognitive impairment, patients who use lithium or other anticholinergic drugs also at higher risk. Patients with diabetes and HIV positive, they are at higher risk. And remember about that first scenario of the EPS that we discussed, the acute dystonia. If you had an episode of acute dystonia at some point early in your life, you are also at higher risk of having tardive dyskinesia. So the best treatment is prevention, okay? So try to avoid using typical antipsychotic medications. There are better options in typical antipsychotic medications, okay? Try to treat the symptoms with the lowest available dose, meaning the lowest dose that you respond to it, that should be the best dose. And once you have the symptoms under control, you can give it a try with the doctor's supervision and doctor permission to maybe decrease the dose a little bit and see how things go. Okay. This is a little bit repetitive, okay, but if we're gonna go from the higher risk of antipsychotic medications to develop TD to the lower risk, so we start with the higher risk with the first generation antipsychotics. We have their Haldol, Melaril, Thorazine at higher dose. Then we have medication like Risperdal. Then we have Geodon, Zyprexa. Then we have Abilify there in the middle for TD, but Abilify is top for akathisia. And then the medications that have less TD risk are Seroquel and Clozapine or Clozaril. Okay. Part of the treatment, like I mentioned before, prevention is try to eliminate antipsychotic polypharmacy. There's no research whatsoever that have proof that you need to be on 2 different antipsychotics to treat schizophrenia or any kind of psychotic state. One antipsychotic should be enough. If they ever tell you or your loved one that they need to be on 2 antipsychotics, go ahead and get a second opinion. Okay. Attempting to eliminate the use of anticholinergic drugs or lithium, that's also important, and seeking the lowest effective dose. Okay. If the patient is in a first generation, try to move into a second generation. If the patient is in a second generation, let's say something like Risperdal or Abilify, try to switch him to something with less dopamine interaction, like Seroquel or Clozapine, okay? And Clozapine, regarding TD, is the best medication for it. Actually, some research back up that Clozaril kind of help to treat TD, but as most of you know, Clozaril is a complicated medication that comes with its perks, so you have to be careful in what route you want to go with it. So the new options that we have are like the dopamine depleting drugs. So basically, this medication kind of erase the dopamine. The most common one and the most famous one that we are using right now is called Ingrezza or valbenazine. Okay, it's one of the latest FDA approval medication to treat TD. Actually, if you sometimes are watching TV, I've seen a lot of commercials that they are promoting the medication. The downside is new, it's very expensive, and insurance companies give us a very hard time for us to be able to prescribe it. The other option that we have, that is a medication to treat Huntington's disease, that is called tetrabenazine or xenazine, also help with the TD. Okay, this is some of the side effects and clinical trials of valbenazine. It's personally I have never used it, but from colleagues that do mostly outpatient, they said that it works and it decreased the movement. Other treatment options that we have is amantadine, Botox, especially for the mouth movements. We can use Clozaril, like I mentioned before. There's some studies that report that clonopin, which is a benzodiazepine, helps. Donepezil, which is a medication for dementia, have shown that it helps a little bit. And we have other vitamins and melatonin that to some patients, they claim that it helps, but there's no enough significant or robust data for the ones that I mentioned here. Okay, so just to summary and finish, tardive dyskinesia is something that is common in patients that use typical antipsychotic medications. One of the main things is prevention and education. Try to limit polypharmacy. Always talk to your psychiatrist to seek for the lowest effective dose. Anticholinergic drugs may increase the risk and worsen symptoms. So, for example, medication like Cogentin or Benadryl, they're not going to help with TD. Antioxidants are low risk, possible preventive, and medications like Ingrezza and Amantadine are some things that we can consider and see if they help. Okay. So thank you very much. Like they mentioned in the introduction, I'm part of mypsychiatrist.com, and we're here to help. If you guys have any questions or any concerns regarding TD or any other psychiatric condition, feel free to visit our website or give us a call.
Thank you so much, Dr. Cordero. We really appreciate your time and this presentation. So if we have questions from the audience, if you want to go ahead and put those in the chat, we'll make sure that we get answers for you. This is such a complex topic.
Yes, I tried to simplify it as much as I could. I hope I wasn't too technical and too scientific, but I think that I did a good job trying to simplify it.
Well, we do know that many of the people in the audience have some experience with this, which is where their interest comes from. So I think it should be fine. I guess one of the questions I have is this specific to tardive dyskinesia and the other movement disorders? Are they more common with the older drugs and not as common with the newer drugs?
That's correct. Actually, like the oldest drugs, they are like the most common ones. Except the akathisia, which is the inner restless. That's the only one that is mostly associated to Abilify or
Okay.
related to Abilify. The other ones, they are completely associated with the older antipsychotic medication, because the older antipsychotic medication, they basically block dopamine everywhere in the brain. With the new ones, they target the specific receptors that they want to block, leading to less side effects.
Oh, okay. And from what you said, normally if you stop the medication or reduce the dose, that can stop this side effect. Is there with the tardive, does it remain long term or?
The tardive dyskinesia, once you start having it, with this new medication Ingrezza improve, but besides that, like before this medication came, let's say 5 years ago, once you develop that, is something that stay with you, and there's not an effective treatment for it.
Okay. We have a question here. I have dopamine increasing drugs such as bupropion. Have dopamine increasing drugs such as bupropion ever been tried, or would it essentially just counteract the antipsychotic effects without addressing the EPS side effects? Obviously, a question from a knowledgeable person.
Yeah, that's a great question, and the premise of the question is correct. Wellbutrin, it will increase norepinephrine, it will improve dopamine in the brain. So in theory, it should help with it, but research have failed to show any improvement of Wellbutrin with tardive dyskinesia.
Interesting. Okay, and so as we wait for, we'll wait a couple more minutes for any questions that you have in the chat. So I have one more. And that is, I know that some doctors and healthcare providers are still prescribing some of those older drugs. Is that connected with efficacy, or does it have more to do with insurance plans and what they'll pay for, or stepped therapy? Do you
Yes.
address that?
Unfortunately, in my experience, two things have contributed to that. The first one is insurance. Because at least, from the hospital, these clinics, they have, well, the patient go there, see the doctor, but if the patient do not have $1,200, sometimes that is a month supply of these new medications, there's no point of prescribing it because they won't take it, because they won't be able to afford it. So the doctors kind of are forced to keep something that at least they're going to be able to afford or get for free to have the symptoms under control. That's that's one scenario. The other scenario is efficacy. Sometimes the patient is so chronically ill that needs something a little bit stronger, such as Haldol or Melaril, Prolixin, because maybe the atypical antipsychotics, they're not strong enough to control the symptoms. So in my experience, those are like the two main reasons of why someone is still taking old school's antipsychotic medications.
Okay, very interesting. So that also gives us here at NAMI some things to think about as far as the advocacy work that we do and where
Definitely.
we can be advocating.
Definitely, and there's some programs. Sometimes myself, involved in this dilemma in the hospital when they are like, I have this 20-year-old patient. I don't want to give him a Haldol shot, or if there are other options. So we try to collaborate with the pharmacy. There are some grants, there are some programs, but for that, it's extremely important that the family is involved, because someone that do not have no support, it's going to be very difficult. So okay, so I have to go every month to the internet, download this coupon, and maybe take it to the pharmacy, and maybe they help out, and instead of paying $1,000, I'm going to pay $55. So when we have family that they're involved, we always try to give them or lead them in ways that they can make the medication more affordable. Because to me, is something that, in having a health insurance or not having a health insurance, it shouldn't be why I choose to get like a bad medication versus something that it can help the patient avoid these side effects that, like I mentioned before, they can be long term, or something that do not have any cure.
Yeah, I think we definitely hear from people, and I know I have a family member that goes through the coupon searching every time the prescription has to be refilled, and so managing that on top of managing everything else can be very difficult. Okay, we have one more question, and this is going to be the last one because we're over time as it is. But it says, you mentioned antipsychotic naive patients can be at greater risk for displaying movement symptoms like akinesia. Have you noticed any patterns with patients who are still antipsychotic naive, but who have taken something else before, like SSRIs, and how likely they are to develop EPS?
No, it's the same. If they've been taking SSRIs, they have like mostly the same risk factor that someone that have never been on antipsychotic medication. It target like different receptors, and the SSRI doesn't have nothing to do with the movement disorders associated with the antipsychotic medications.
Okay. Okay. Well, thank you so much, Dr. Cordero. Thank you, everyone in our audience, for attending. If you have further questions, you can go ahead and put them in the chat, and we'll leave it open for a few minutes, and then we'll get answers to those from Dr. Cordero, and we can send those to you. Or any other way that you want to reach out, you know where to find Dr. Cordero. So thanks so much, everyone. Have a wonderful evening, and we will see you on Saturday at the NAMI Walk for Mental Health Awareness.
Have a nice evening, and thank you for
Thanks.
your attention. Bye-bye.
You too. Bye-bye.